that's okay. Yes, so as you have probably already seen in the program, the title of this talk is Thinking of Implementation Science in your research, or it could also be in your clinical development of different things. Start where you are. And the topic today is talking about what to do pre-study. And then we have a later talk about during the study and then a post-study. And today we are especially focusing on demystifying some of the theories and models and frameworks, but also before starting to demystify them, we want to explain the models to you. And along the way, we will give different examples. And by the end of this session, and I hope you will last that long. I know it's very early morning for some of you and it's very late night for others. And then we are some that are lucky that are in between. And it's midday here in Europe. So, but by the end of the whole series, so this is just a part of it, you would be able to define implementation science, select an implementation science framework that would work for the work you are doing, the projects you are doing. You would be able to apply an implementation science framework in your research and reflect on how you could bring implementation work into your research. And also find the resources you need. Some resources will be given today, and then others in the other talks. So it's a bit of a cliffhanger. You can already feel, right? You need to come to the next talks. And today we will, I have already said that a little bit, talk about what implementation science is, what are some of the frameworks that you could use and how could they be used. And then Suzanne is giving sort of, or digging in. We will have small examples along the way, but Suzanne is digging into a slightly bigger example from her better conversation with aphasia. And it's not just the happy example or the perfect example. I know Suzanne will also focus on, oh, if I had known that, I would probably have done things differently here and there. So, and then, as I've already said, debunking the implementation science myth, and then also some tips and discussion in the end. Yes, so over to you, Kirstine, and tell me when I need to flicker through to the next.
Everyone, and yes, thanks so much for having us. This is a great opportunity, we thought, to sort of unpack implementation science a bit. I've been part of the working group 5 for a while, just sitting in the background because I'm very interested in CPT. And there's been quite a lot in comparison to other areas that has looked at implementation with CPT. So I think it's a really nice way to frame some of these concepts. And I think that people probably have different knowledge and experience with implementation. So we're going to try and keep it simple though, because the the difficulty we often find is it can, and sometimes I think it's our own fault, the implementation scientists, you know, we love a good theory and then suddenly there's too many, and you know, if you're new to that, it just can seem a bit complicated, I think. So we're going to try and keep it simple. Hopefully we achieve a little bit of that, but if I do start to go a little bit I don't know, too detailed, please someone stop me. Yeah, and I guess the whole premise of this series is that we want people to really think about their own research and where you're up to. There's not really the right time to start, but we would encourage people to start as early as possible. But there's opportunity to think about implementation at many different phases in your research. So today we're starting at the beginning, but I think as Suzanne will talk about with her example, you know, looking back, you could think, oh, maybe I could have done that, or maybe there's still a chance where I can add some things in. So Natalie was co-author of a paper, and maybe you can pop that in the chat at some point, about starting where you are, so I think that in the perfect world, if you right at the beginning, this might be a really good chance to think about how you can embed some of those concepts throughout. But if you're not, don't worry at all. So that's sort of the thinking behind the whole series. So yes, we can go on. There's a few definitions here. Yes, this and I guess, again, people might be familiar with some of these. And they all do mean slightly different things, which again is a bit annoying, unfortunately. So we have knowledge translation being more, they're both, there's a slide in a minute which I'll show you, but I think they're both looking at, so knowledge translation and implementation, it's looking at taking knowledge or evidence and putting it into practice. In the earlier literature that I read, it was almost like a linear process, and that concept of you do implementation or translation at the end. And I think now we're seeing more and more that people are recognizing it should be collaborative and a process that you do start earlier. So that's where we see some things like KTE, or that knowledge transfer and exchange, which is more about that interaction between end users and researchers, where ideas come together. And with implementation science, it's really the study of the methods of how you do that. So we want to know what is actually happening. What is it that is contributing to that intervention or evidence being implemented successfully? What are the mechanisms that helped to achieve that? So that's some of these terms that you probably have heard of. So if we look at the next slide, I just sort of popped this in before because I realized I probably wasn't going to do a great job of explaining the difference, because I know what it is, and sometimes it's hard to sort of go back to that, getting those really clear distinctions. And so I just popped the link. I got this. The Canadians do such a lovely job in implementation and knowledge translation. So they have a bunch of great resources. And this is just from one of their handouts, which goes through. So again, I can share that afterwards, and just pop that link probably in the chat as well. So really, I'm just trying to understand that black box. So knowledge translation is looking at translating or implementing. Sometimes it's used interchangeably, knowledge into practice, but the implementation science bit is trying to understand, well, what and how. So I guess if you ever think, what is it again? Maybe think of the black box. And unfortunately, there's no easy answers. So what's in the black box? We're still trying to work out. So if we just go into the next slide, thanks, Jutta. You might have also heard or seen this T0 to T4, and I just sort of wanted to mention it briefly. Again, it's looking at that sort of, it's more of a linear process. And when I first started, I feel a little old now, because when I started in implementation 10 years ago, this was talked about quite a bit. And I really had to understand what it was to understand what it wasn't, I guess, in a way. But if we look at that T2 down the bottom, you can see it's talking about translation to patients. So I think this concept, or the whole sort of framework here, is looking more at that basic science, lab, all the things that I don't really understand, because all of my work is with people. So we're already ahead on that trajectory. And so I just think it's sort of a little bit in that traditional mode of developing perhaps drug trials and interventions, and then moving, or animal trials, and then moving on to people. So I think it just to put in, I think often, again, it's that concept of implementation happens at the end. And as we're going to talk about, it's not something that just easily happens. And so often there's a bit where in a grant application, it might say, well, how are you going to disseminate this? So you can see, sorry, I don't have the cursor, but it says dissemination and implementation. It sort of goes along this process. And they would say, well, how are you going to disseminate that? And I think there's an assumption that that will just lead to implementation. But we have certainly seen that that isn't the case. It would be nice. It is for some things, but I think our areas are very complex. We're talking about complex interventions, particularly with CPT. So yeah, so that's just a little bit that it is different. Implementation is recognized in this, if people are talking about using this framework. But for me, I think we're always dealing with or working with researching patients. So I think we're always considering implementation. So the next, just to sort of go through, some of the key components. I think really when we talk about the black box, you will probably have noticed that there's an emphasis on that theory. So the underlying theory, behavior change theory. So that's really important for implementation scientists like me. I love to know what the theory is, why they chose the theory and all of these things. And there's a lot of different theories, so we're not going to go into too much about that, but just to know that it is part of it. We want to then use that theory to help to design these behavior change interventions that will, we hope lead to that improved service delivery and then patient outcomes. But the key thing with implementation science is knowing that the context is really important where we are delivering services. It's complex. We're dealing with systems, healthcare systems, people working within those systems. And then we have, of course, the consumers and people with aphasia and their families that they're working with. So one thing that's been really strong in the implementation literature for a long time is this bottom point that it's really important to tailor implementation interventions or strategies to barriers that we identify. So we'll talk a little bit more about that on the next slide. So what does that actually mean, and what do we mean when we're saying a tailored implementation intervention? So essentially that we need to understand that context that we're talking about, that we are considering for implementation. And the evidence has come from a number of systematic reviews. I don't know what's happening, sorry. That it's more effective if the strategies are tailored to those barriers, but not always, of course. It's not always that simple. And when it is effective, overall the effect size is small to moderate. There's a lovely review that I will try and find as well if people are interested. And I think on average, it's about an 8 to 10% improvement in practice is what we're looking at overall. And that is, I think, still showing that small to moderate effect size, but just thinking about bang for buck, knowing how difficult and complex it can actually be. So what sort of change we're looking for overall, it could still be really, really meaningful. But we may not be expecting huge changes in practice, but that small change can make a big difference. So unfortunately for us, and this is what we're all working on in our implementation science group and those of us involved in this area, there's not a lot of evidence on the best way to do all of this. So we don't know how, or we do know how, there's lots of different ways, but there's not really consensus on the best way or the most effective way to determine what these barriers are. There's no strong evidence on how to make those decisions if we have a lot of barriers, which are the most important ones to address, because often we're seeing a long list of barriers. So do we address them all? There's been some studies looking at one thing and then they look at 10 things, and sometimes, they both improve. So similar to the intervention studies that we're seeing, the implementation research is trying to unpack these sorts of things as well. And again, looking at, how do we the evidence for actually selecting those elements of an implementation strategy. Again, there's lots of things that people are doing that are informed by theory, but again, there's no evidence that says one way is better than the other. So that's lots of unknowns, essentially. Thank you. So what are we talking about when we say we're developing or we're going to develop and trial an implementation intervention or a strategy? And the reason I've got them both there is because sometimes it can be a bit confusing to say an intervention if we're talking about implementing an intervention like CPT, but then you have an implementation intervention to implement the intervention that is CPT. So I think in certain areas, it could also just be where you are working. We often would just say implementation strategy, and it essentially means the same thing. So usually we're talking about strategies or an intervention, like an implementation strategy or intervention that's targeted at healthcare professionals. So that tends to be the majority of research, but it also can be at other levels. So it could be at that individual level, clinician level, could be at the team level, organization, policy, and even the patient level as well. So I've already talked about the tailored intervention concept. There's also some thoughts that it shouldn't just be about barriers, that there's some really important facilitators as well, that if we tap into those, that can really help change practice. But sometimes we do focus a lot on the barriers. Just to shout out to those facilitators, they're really important as well. So I guess just thinking about, I really like this example. So we've talked about we need to consider the context, we need to know what the barriers are. So there's a lot of different ways we can think about how to do this. And this early model by Pathman, I really like. It's very simple. So if we're looking at guidelines, implementing a clinical guideline, you need to be aware of it. Firstly, you need to agree with it. Then you need to adopt it into your practice and adhere to it. So we can just think, well, where is that breakdown happening? So it's quite an early model that I like. And this example is just, some things in hand hygiene. This research looked at a strategy that was very effective in changing practice. So a lot of research has happened in hand hygiene. And so I've actually looked at quite a bit. I guess it was an early adopter of implementation research. So although I guess it's one of those things that's quite simple as well, it has a big impact on health outcomes, but adherence is generally low, and anyone who's worked in a hospital has done the mandatory training and knows about all the auditing that happens with hand hygiene. So this here says that it's approximately 40%, and interestingly, it tends to be that it's higher in nurses than doctors. But then there were also, I was reading the other night when I started to go down a rabbit hole, the adherence is very high in surgical teams, because there's sort of a ceremonial element about the hand hygiene. You always see it on Grey's Anatomy. They're standing there doing their excellent hand hygiene. So in one of these studies, they looked at the barriers, and there was a long list, but the biggest things that they found in the study was that workplace culture. And this study by Hewis was actually with nurses, and that perceived importance. So just thinking, yeah, I mean, it's important, but it's not that important. It's not going to matter if I miss it occasionally. So not really having that belief that it is actually going to make a difference if they don't do it all the time. And then just, yeah, it sounds simple, but you can see that there was a really big increase. So if I say, it's usually 8 to 10%, we can see it improve from 20% at baseline to 53% adherence. And this strategy that they developed was looking at the social influences and the leadership. So finding that if there were people within the team who were the team leaders and the nurse unit managers who were really promoting and modeling good hand hygiene, that flowed on to the rest of the team. So we can just sort of see, hopefully there's some linking between those barriers, what they did and how that improved practice. So then if we just have a little look at some of the facts on the next slide about implementation science. You might have heard some of these. Some of them are a little old, but they're still true. And this first one is probably the most common one. I remember when I first heard it, I was shocked and horrified. It's always stuck with me. That it takes an estimated 17 years for only 14% of new scientific discoveries to enter day-to-day clinical practice. So I'll just let that sit with you. You can put your hand up if you've ever heard that before. I've seen some nods, yeah. So we don't want all the wonderful things that we're doing to take 17 years to change practice. So that's a huge reason. So just if you take that away, just think one thing away, just think about that. A lot of some similar things. So a third or less of guidelines are routinely adhered to. So think about, going into hospital with the stroke. We have our lovely stroke guidelines and stroke pathway, and we want to be reassured that anyone we know would get 100% of that care. And unfortunately, that's not the case. And there's another, a landmark study from the US that showed that adults received 55% or less than 55% of recommended care. And that was looking at a number of clinical practice guidelines. So just some facts. And I think the thing is, we know it doesn't, as I said before, just magically happen that you get these amazing findings, and we can talk about like better conversations for aphasia. Like that's an incredible resource as a clinician. I just think, oh wow, I would have loved that. But how many people are using it, and it would be just great if we could insert it into practice. Like, here you go, here's this tool, off you go now. And that would be great, but it just doesn't happen. So we need to do something, and that something hopefully is implementation science. I realize I'm talking a lot, so sorry. The next slide, thank you, is just another figure, really just looking at that leaky pipe. So the research to practice pipeline. Just all the time there's new evidence coming out, particularly in our field. I feel like it's really hard to keep up, and I'm full-time in research. So I think for clinicians, there's lots of opportunities along this pipeline, a pathway at the top, that you can see this knowledge in blue is leaking, and lots of opportunities that they might miss information. So just remembering that, I think is really helpful, and we can try our best to stop some of that from happening. So now we're going to talk a little bit about some of these frameworks, and we just picked a couple, but I think I'm going to let Natalie do a little bit of talking now.
Thank you, Christine. We love what you're saying, and we want you to keep going. So thank you very much. And thank you to all of you who are here today or potentially watching the recording. It's really been wonderful to work with CATS and collaborate across these different working groups. So I'm going to talk just very briefly about implementation science frameworks. There are actually close to over 100 of them. So if you are overwhelmed by implementation science theories, models, or frameworks, you are in very good company, because we have so many, and it's very similar to theories in terms that there's always a new one coming out, and everyone wants to kind of make their own. But I wanted to refer people to Per Nilsson, who has an article, and I'm happy to put that in the chat. It's an open access article called Making Sense of Implementation Theories, Models, and Frameworks. And he really walks us through the idea that there are some differences between theories, models, and frameworks. As Christine said earlier, we want to focus on the simplicity of what we're doing as we're introducing this topic today. So for our purposes, we're referring to them in the same way. But if you were to refer to Per Nilsson's article, he talks about how implementation frameworks can be divided up into process models where there are frameworks that are really working through the process of implementation, determinate frameworks where you are trying to figure out determinants of behavior or facilitators and barriers, as Christine was talking about earlier. And then there's evaluation frameworks. So let's say you were trying to evaluate the success or not of your implementation efforts. And then we, of course, have classic implementation theories. So one of the objectives of today is that we really want to acknowledge the overwhelming nature that there are all of these frameworks, but also point out that we can still answer a lot of these questions that we have with these frameworks. So these frameworks can be tools to help us answer the research questions that we have. So I'm gonna pass it off to Christine again to talk about an example of a determinant framework, the theoretical domains framework.
Heard me talk about this before, which some of you may have done. I do quite like this framework, and you do see that with people working in implementation where they use a framework and they get to know it, so they do use it quite a bit. And I think that this is not saying that this is the best framework out there, but it's just one that I've had experience with. So it is actually based on something like, oh, here it is, 33 different behavior change theories. So it's a synthesis of a number of different theories. And it's quite useful in my experience, and there's some other published literature out there just for really looking at those barriers and facilitators and helping to understand the context. And then you can go from that, and then as we talked about earlier, you can use that information to then design some implementation strategies. There's been some people who say, which I do quite agree with, that this framework might be very good for the individual level, but maybe doesn't look so much at the context. So even though I've said it does look at the context, which it does, you will see there's a little circle that is related to the context. It's sort of given equal, I suppose, you know, there's not one area that's more important, but I think we've seen context is so important. And there might be other frameworks that look at the context in more detail, but it is there. So I just thought I'd give you a little example on the next slide of one recent study where I interviewed clinicians. So the way I used it was I conducted interviews with clinicians about their perceptions of barriers and facilitators to implementing an ICAP, so intensive and comprehensive aphasia program. And these were the main barriers that came out, and you can just see in the bold how they were linked to some of those theoretical domains. And the one that always, I think in every study where I've used the theoretical domains framework or the TDF, it's always the number one barrier, lack of time and staff. But, you know, so I think understanding, you know, what exactly, it's not only helpful to say you know, it's this domain. We need to understand actually within that, what are the key things that are happening. And this has just been really useful. We've taken this information and we've developed an implementation strategy that we're trialing here in Australia to implement this ICAP. Yeah, sorry if you just see my dog walking behind me. So that's my experience with the TDF. So that's one of the frameworks we just thought we'd draw your attention to. And then I think Natalie's going to talk about the I never know how to say it. Is it Paris?
I know. I always say Paris, but I'm not sure that that is correct. But that is what I call it. So this stands for the Integrated Promoting Action on Research and Health Services Framework. So this is also a determinate framework where we're really trying to figure out what are barriers and facilitators to implementation of the evidence-based practice. And so when we think about this framework, and I'm not sure how helpful the spiral diagram is, so this was something that was new based on a revision, but successful implementation is really a function of facilitation by the innovation plus the recipient of that innovation plus the context. And I'll try to break some of this down in just a minute. But when we think about facilitation, we're really thinking about those facilitators, as Christine was saying, and we're thinking about what is going to make this easy for people to uptake. And so many people talk about how, you know, when we think about an innovation such as the iPhone, there were many different prototypes that are probably, you know, sitting in closets everywhere that were not iPhones, that maybe had similar functions, but they were hard and they were less intuitive, and they were not as readily integrated into society. And so when we think about facilitation, that's what we're thinking about. When we think about the innovation, that's whatever it is we're trying to implement. So Christine earlier talked about hand washing. This whole concept is about, this whole speaker series rather, is about communication partner training being the innovation, and then the recipient. So who is the recipient of our interventions? And again, we have a bit of a complex situation because yes, we have the person who is living with aphasia, but we also have their communication partner, and then whichever healthcare staff potentially across the continuum of care where that person with aphasia is receiving services, that is also potentially part of the recipient of that innovation. And then we have the context. So as Christine was saying earlier, where is the context where this innovation is being implemented? And it would be so much easier, I think, if our innovations were delivered in a vacuum where we did not have many contextual factors such as organizational culture, organizational climate, leadership, you know, direct care staff, knowledge and skills, all of these factors that influence context. So when we think about this framework, we want to think about what makes it easy across these levels of the innovation, the recipient, and the context. And so if we go over to the next slide, this is a project that I did with my colleague, Rebecca Afu, and we were essentially looking at pre-study what are certified nursing assistants' perceptions of external memory aids for people living with dementia. So this project came out of an earlier project that essentially stated that speech language pathologists do not implement these communication tools in long-term care communities or other healthcare settings because they train the nursing assistant and the nursing assistant never implements it. So in this project, rooted in this IPARIS framework, we looked by trying to collect data directly from nursing assistants to look at characteristics of the innovation, which in this case was external memory aids, the recipients, which at this point was the people living with dementia and the certified nursing assistant, and then the various aspects that were going on in the context. So interestingly, if we look at the data that we got directly from certified nursing assistants, they actually had very favorable responses toward external memory aids. And interestingly, that the perceptions of the innovation, according to the speech pathologist and the certified nursing assistant, were quite different. And so if we go ahead and go over to the next slide, there we go. In terms of the context, most nursing assistants reported that if someone trained them to use the memory aids, they would have enough time to do so. So it was really interesting. I think by using this framework, we found that the lack of uptake of these memory aids for people living with dementia is not solely due to lack of buy-in or lack of time on the part of the certified nursing assistant. And so this framework allowed us to interestingly take a look at, what are we thinking about in terms of training methods? So we realized, current training methods are likely not considerate of these nuances of implementation, because in this particular study, we had 144 nursing assistants. They had very favorable beliefs about how useful the innovation was and how they would help both conversation and independence and activities of daily living for people living with dementia. So, there was a bit of a mismatch between the speech pathologist and the nursing assistant. So when we kind of, again, this is pre-study work, as Yuta was referring to earlier, introducing this series, this kind of gives us information about if we want to design a coaching or training program, we have to be cognizant that potentially this mismatch in perceptions could really influence implementation. And so I'm going to turn it back over to Christine to talk about one more framework, the knowledge to action framework.
As well, some of you might have seen it. So I think this is one of the process models, which is possibly why I like it, because it gives you a little bit of a step of what to do. So in the middle, we have our knowledge creation. And so this is looking at building the evidence base and synthesizing the evidence. And then we have our thing that we're going to do. So that's our knowledge creation in the center. And then around the outside, we have our action cycle. And so this is where we really understand what's happening. So identifying the thing that we want to do, is it happening? Do we need to do it? I guess in a very simple form. So if we're looking at CPT, what is actually happening? And that sort of flows onto that next box, looking at adapting. Well, how would it happen? Do we need to change anything about the intervention or the recommendation? And understanding the context. So this is where we see the beginning phases, really understanding the problem, the context, what are the barriers before we go on to then selecting some implementation interventions or strategies that are tailored. But the thing I really like about this model as well is that it goes on to then say what we should do next, because often we just focus on the first bits. So we can think about how we then monitor and evaluate the outcomes. And we're going to talk more about that later in our other series. And then, of course, sustaining that implementation is really important. The bit that I like about this is it's cyclical as well. So I'm going to talk about an example a bit later, where I did use this knowledge to action framework to sort of hang the implementation for a CPT study that I did. And I just really, as I said, I just find it very helpful as a researcher to sort of follow these steps, if you like, but know that you can always review and change it. And I think that, as we've found in a lot of our work, we can do this really great work at the beginning, which is what we're talking about, understanding those barriers and planning for implementation. But then once we try, often new things come up. So it is a process. So we thought this is a good time to sort of, okay, we've talked about these implementation strategies. What do you actually mean by that? There are a lot. The one that we see most often, and not just we, but I think in healthcare, the default strategy tends to be education. And I like to think, because I've been thinking a lot about CPT, how we would change the behaviours of our people with aphasia and their family members that we're working with, or the healthcare professionals. Is it enough to give them a handout on the strategies we think they should use? I think that's not really training. So I think there's been a lot of research to say that some educational materials do work to change practice, but it depends on what it is. And it depends on what those barriers are that we've already discussed. So I think that passive dissemination tends not to work, but it's not a one size fits all. We often have educational meetings like now. I wish it was more interactive. It's a little bit didactic. And I think there's evidence that the more interactive it is, the better outcomes there are for changing practice. So again, thinking about what are we doing with our CPT? Are we just providing education? Are we giving people a chance to ask questions? And I think we do that. But there's a lot of evidence that some of these things work some of the time, but not in all situations. And it depends on having that really good understanding of the context and the innovation itself, or the intervention itself. So again, audit and feedback can be really helpful, but if you don't have the feedback bit right, it probably won't work. So just auditing and not giving people results, or they don't look at the results, or how are you giving that feedback? So there's lots of different things, and there's been, I think, systematic reviews on every single one of these things. So again, I won't go into this in a lot of detail, but there's implementation strategies are probably things you've done and heard of. So I guess just looking at what you're doing and why, and trying to think about how that actually links to those barriers is a really important step. So if we just look at one option in the next slide of ways that you can actually select and come up with these implementation strategies for an intervention. This is the behaviour change wheel. It's got the link there, and it's got a nice workbook. So I like that as well. It's an ebook. You can purchase it online, and it just really steps you through those processes of, once you understand those barriers, what can you actually do? What are some options? And then it gives you some things to think about of what might be feasible. And it gives you some guidance around that. So again, we're not going to go into that in a lot of detail, but that's just one way that you can take those barriers that you've identified and actually look at coming up with an implementation strategy. Oh, and I was going to say too, there's an app, which I like as well, because my book isn't next to me. It often is. I can see it behind me. It was in my bedroom for some reason for the last 2 weeks. So I often have my book, but when I don't have my book, I like to have my app just in case I need to look up a behavior change technique, which I do. So that's free as well. So just if you want to have a look at that, I recommend. So I think Natalie's going to talk about the CIFA and ERIC matching tool.
Yes. So thanks, Christine, very much. That's very helpful. So this is another free resource in terms of selecting implementation interventions or implementation strategies. So one of the frameworks that we did not talk about yet was the consolidated framework for implementation research. So when I was speaking earlier about frameworks, I mentioned that they were close to over 100 different frameworks to choose from. And when this CFIR framework just came out in 2009, the goal was to take the useful bits or the useful components of all of these theories and consolidate them into a working model. And actually, I believe a CFIR 2.0 just came out where they solicited a lot of user feedback and implemented it into this next iteration of the CFIR. And they also talked about how a new level of importance on the level at the level of the patient or the client and what their priorities are emphasized more in this model. So if you were to map out the barriers to the implementation of your innovation through the CFIR, you could potentially use this matching tool here. So you can see the website here, cfirguide.org/choosing-strategies. And if you are not familiar with ERIC, so this was an e-Delphi panel where several implementation science researchers tried to lay out what are implementation strategies, what are implementation interventions. And they actually came up with 73, and then they grouped them into buckets from there to make it a little bit less overwhelming. But if we go over to the next slide, I have kind of a screenshot of what this might look like if you were to go on the website. So essentially, it gives you the references for where these strategies have come from. So again, we've got the Powell and colleagues who originally came up with these 73 ERIC strategies. And then we also have some additional references. And the idea is that if you input your barriers into the strategies, if you go ahead and go to the next slide, if you input the barriers to the implementation of your innovation into this Excel sheet, it will let you know what potential strategies might be for you to try. So for example, I put in some of the barriers that I have to my implementation innovation, which is again, communication partner training, mostly nursing assistants for people living with dementia, as administered by a speech language pathologist. And barriers are usually time, other issues in terms of communication. So I inputted those barriers, and I know it's a little bit hard to see, but some key implementation strategies that pop out are the important nature of identifying and preparing a champion. And we've really seen that on the ground with some of these data collections, that wherever we are trying to collect data in a local skilled nursing facility, for example, designating a certified nursing assistant as the champion of the project, you know, ideally so in collaboration with the speech language pathologist, really tends to be a very effective implementation strategy. Some additional strategies that you see here are creating a learning collaborative, identifying early adopters, and opinion leaders, meaning that when we think about an innovation such as communication partner training for people living with dementia, many times this intervention is more well received if coming from another nursing assistant as opposed to an outside person like a research assistant or even a speech language pathologist, someone that's not as connected to that nursing community. So again, for every project, depending upon your barriers that you would have identified via the CFER, hopefully this tool could help you come up with potential strategies to support your innovation implementation. So if we move on to the next slide, what we're going to do next is talk about specifically how others on the panel here today have used implementation science in planning their communication partner training studies. So I will turn it back over to Christine.
Thank you. I don't want to talk too long because then I want to have lots of time to hear Suzanne's thoughts and then have some discussion as well. But I just did want to add, I think that element of facilitation is really important. Who is going to listen to you and why? And I think as an external researcher, going in to do projects, studies for a set period of time, that's quite difficult because you're not on the ground there all the time. And I guess having that presence, when the study finishes, then we've found it's difficult to sustain that implementation without that champion or facilitation happening within the site by somebody who's really driving it. So I think there's a lot more to understand about the best way to do that, and that's something I'm really interested in. So this next, the study that I wanted to talk about did use some facilitation, and it was I was so happy to be involved in it because I didn't actually really do anything. I evaluated it and I was there the whole time, and I helped plan the implementation. But really, I think why it worked was because it was basically facilitated by the senior speech pathologist who worked there, who wanted to implement training for multidisciplinary staff in the rehabilitation unit. So it was just a really great opportunity to look at how that could happen. And if we did try to design and test a tailored strategy, could this improve the outcomes in terms of their use of supportive communication strategies? So the speech pathologist, Julie Scott, who I just love and is amazing, so shout out to Julie, she provided the training, and she'd been trained in the UK a number of years before in Connect and had all the resources. So we went with that. So I didn't have to develop it. So it was really looking at the implementation. So it wasn't actually testing, the intervention. It was looking at the implementation strategy that we developed. And we did some preliminary focus groups to identify those barriers. And so I used a number of frameworks. I used the theoretical domains framework to look at the barriers, but I also used the knowledge to action framework that I mentioned before, because we did 2 rounds of implementation. So we did try and go around the circle, and we had planned to do it another time, but COVID came along and everything was really, really hard. So we only did 2. It was a big effort. And you can see it was a small sample size. We had 13 multidisciplinary staff, but it was 2 groups, and I think it was about 6 months in between. And what we did was then we obtained some feedback from the staff on what they thought about the way it was implemented and what worked and what didn't, or what helped them implement it in their practice, I should say, and what things they would have liked. And so then we modified that. And the 2 things just at the bottom there were the things they identified. So they wanted more practice opportunities. So I think just going back to how are we going to train people to provide CPT, they want also to actually, use the supportive conversations strategies themselves. They want that practice opportunity, because I think what they were saying is, yeah, we got it in the session, but then over time we found that we might not have used it for a while, or we didn't have that confidence when we were out there on the ward. So they really wanted that follow-up support from the speech pathologist to keep them accountable as well. And again, because we all just think training's great at the time, we're also motivated. But then when we go off back into our normal routine, it's that actual bringing in those things that we've learned and changing our habits can be quite difficult, can't it? So that was a really key thing, and that's come out from other literature. So it's not just from this study, but it really helped us understand what was happening. So then if we just go on to the results of that, but I really just want to show this to actually show you what the implementation strategy was that we had designed. So this is with input from the staff, what was feasible. They could have 4 hours. That was the maximum they were allowed. So we just, so we had to go with what they were given permission to attend. So we had our 3-hour workshop that Julie provided. And then there was an hour session where she had trained people with aphasia to come in, and the staff could practice using those communication strategies with the aphasia volunteers. So, I mean, I think that's similar to a lot of other CPT programs, and it was based on Connect, like I said. But you can see then we tried to just draw out what the key elements of the strategies were. So yes, we wanted to have the education, but we also wanted to really have those active training elements for staff. So there were videos and case discussions, and there's things here on the slide, but really wanted to harness those beliefs. So having the patient case studies and the videos, I think they're always so powerful. And then, talking about where people missed out because they were left out of the conversation. And then really that enablement. So really giving people success, a positive experience of using those strategies, practicing with the consumer volunteer, but then actually going out onto the ward, as I said. And then I think at the same time, they got some additional resources, and they had a student project who they came in, they made like a communication station thing where they could all use resources, and they had some guidelines developed and science behind the bed, and there was a whole lot of other things that happened. So it wasn't a one-off thing, it was a process, and it took about a year, and we found there wasn't a significant change in practice. I think we looked at the MSC for the way the staff were communicating with patients on the ward. They also completed some surveys, and there wasn't really a lot of change. It was a small improvement for that first group. Again, it was a small group, but we did see a much bigger change in the second group, and the focus group feedback was much more positive. They just said that it really had changed what they were doing. And so that just, I think having the 2 cycles and really understanding how we could, what we're trying to do with the implementation strategy, and then changing it based on the feedback was a really nice thing to do. And yeah, so our conclusions there, which again are not, I think a lot of people are already doing this, but for this context, this, really seemed to work, where we had not only the education and training, but those practice opportunities. And I think that's the thing that's often, we want to do that, but it's really, really hard. And that's what Julie was saying, the speech pathologist, to get those volunteers in, to train them. They couldn't be people that were still patients, obviously. And then, for various reasons, they might have moved out of the area or had other commitments, or just coordinating all of that when you've got a full-time clinical job. Just was really difficult, and then getting the staff. So it was all of those process things behind the scenes. In the end, although we saw some really good results, it wasn't sustainable as a model, particularly with the actual practice with the volunteers. But that was the crucial thing. everyone loved that, and everyone said that was the thing that made them feel confident, but they just couldn't keep it going. Yeah, which is a real shame. So yeah, that's something to really think about. Sorry, I just might have gone a little bit off on a tangent, but that was the example that I wanted to talk about. And then I think, Suzanne, you were going to talk about better conversations.
Yeah. Okay, so over to me. And I just want to say before I talk about any of this stuff, that I am in the same boat as all of you listening. So I don't consider myself to do implementation science yet, although I'm literally hour on hour realizing that perhaps I do. And so this is just my thoughts on implementation in hindsight. So the Better Conversations with Aphasia CPT work to design the program and to test it and then to release it to people and help them to use it was done at a time when we weren't all talking about implementation science. I knew nothing about implementation science. And so this is a really kind of, in hindsight, reflecting on what we did and what I feel I'm learning. I won't say I have learned, because I feel like I'm still learning. And even just listening to Kirstine and Natalie this morning, I've jotted down some other things that I think that we can and have done in the Better Conversations work that's about implementation. So what I've done here is just laid out what we did, maybe in a more kind of traditional way. This project was set up to design a communication partner training and to then test it, and then to launch an online resource that was linked to that intervention and also included resources about how to use it. We have over the years also done a user survey. So we did an online survey of people using the online resource, using Better Conversations with Aphasia. And we also have and still continue to do lots of things around training SLTs, and just generally creating a community of practice, a group of people who are interested in Better Conversations with Aphasia and want to kind of regularly hear about it and know more. So those are the kind of things that we did, and that happened over years. So that wasn't all part of one project. And I've just been reflecting really on what we did. And what strikes me from, can you just press the button? Yes, thank you, Yuda. Yeah, that what strikes me about what we did is that by devising and launching our online resource, which included knowledge, but also had clinical examples, lots of videos, and linked to that, we have training days. And by doing our user survey, where we asked people, are you using Better Conversations? In what ways do you use it? What are the barriers to using it? In what way would you use it more if it were different? And also in our creating our community of practice, where we do things like kind of outreach, I suppose, to pick a word that the implementation world talks about, but we might talk about offering kind of case study surgeries. We do a lot of social media work. We have our conference now that we run every 2 years. So we did lots of work there. And in hindsight, all of those I can now see are implementation strategies, but I never conceived of them in that way. And I find it really helpful to identify them now in that way. And also something we did very early on, a lovely piece of work that Nicola Sermon did when she was working with us on the original Better Conversations with Aphasia project, where we were designing the intervention. She did a survey and then some follow-up focus groups with speech and language therapists on their usual practice in communication partner training, and their views of barriers to using communication partner training, which I can now see was a really great thing that would have bolted on, was a really good implementation focused approach. And that also could have been a really nice implementation strategy, that we'd uncovered those barriers first and then we would address them. But sadly, we didn't ever feed that into the intervention design. And so part of what I wanted to do today was just to be really honest about this stuff and say that, you know, with the best will in the world, we did a good job at the time, but we missed a real opportunity there. And so learning about the barriers and just learning generally about, for me, about implementation science, I think is really giving me a different way to view what we did in our original study, which I think is really helpful for thinking about doing things differently, really. Yuda, could you move on to the next slide? So we did that user survey. So what I did when I was thinking about what I'd say today is I went back to that and I looked at what our key findings were. We didn't publish that work, partly because the numbers of respondents probably weren't as high as we'd wanted at the time. But we could have done a bit of work to interpret what we'd found using the TDF. So something Kirsty told us all about earlier, so the theoretical domains framework with all of these nice areas. And so what I did was just, in hindsight, thought about the barriers to BCA use that we'd uncovered in that survey and how they might map onto these particular areas of the TDF. And no surprise, Kirsty, time was number one top problem with barriers, top barrier to BCA use. People also talked about finding it challenging to provide elements of the BCA interventions. So the video feedback is usually the thing that people feel they need most support with, they don't feel confident with. Also outcome measurement came up. So maps really nicely onto the skills, beliefs about capabilities part of the TDF. Just having enough knowledge of the program also came up as a barrier. And then there were factors around the person with aphasia and the communication partner themselves. So their motivation and their commitment to the intervention, which I can now see that we could understand better and unpick more if we were thinking about the social influences and understanding the barriers generally using this kind of framework. And that kind of understanding would lead us to some implementation strategies that I think would still be really useful to do as we take this work forward. And then there's one last slide, Yuda. Yeah, so I was just reflecting on what could we have done differently, and I think these are the things for me. So I think that we could have fed knowledge of implementation barriers and context of delivery into the intervention design. So we did that work, we learnt what SLTs were telling us, but we didn't feed it in. Well, this is definitely with hindsight, but in future, I will use an implementation framework from the outset. We could have understood the barriers more in terms of changing the SLT's behaviour. We did a lot of focus on behaviour change in terms of the intervention itself, changing the behaviour of people with aphasia and their communication partners. But never have we really used that same framework to understand the barriers to implementation for speech and language therapists. So I think that's definitely something we could have done differently, or we could still, in fact, do. Also, we could have done focus groups with speech and language therapists who were using BCA with a focus on asking them questions around implementation. And that's something that we haven't ever done. And yes, now that we have a growing band of people in our field who are developing implementation science expertise, I think it will be easier for us all to invite people onto our teams who bring that expertise. So those are my, in hindsight, reflections on the Better Conversations with Aphasia CPT work. And I'm really excited about what I'm learning about implementation science and just the different lens it gives me to understand the problems that we're definitely facing, but it's a whole new way of thinking about it. And then I'm definitely going to go away and use some of these tools to kind of impact our barriers that we understand already and come up with some implementation strategies that could really help us moving forward. So thank you, that's what I wanted to say.
And I am aware that the time is running. Kirstine, I don't know if you are next, but maybe sort of leave us a little bit of time for.
Yeah, I wonder if maybe we could leave up the next slide and then invite some comments and questions whilst that's up, the list of myths.
Yes, I think that's a great idea. This is really, you know, thinking through just anecdotally what kind of, well, we've been talking a lot about barriers this morning, what barriers there are to introducing implementation science into a program of clinical research, such as communication partner training. And you know, one, as we were talking about, one of the major myths is that once you choose a framework, you're stuck with it forever. And that's really not true. As Kirstine mentioned, you know, she used TDF, she used knowledge to action. You don't have to use every bit of the framework. You can use parts of the framework that are most useful to you. It's not going to ruin your research. No matter what happens, you will learn something. So implementation science is all about the process. And if you realize, you know, maybe I picked the wrong framework, that's okay. You will have learned something. You can also use multiple frameworks at a time. I was speaking to an implementation science researcher recently, and they talked about they used one framework to collect their data and another framework to write up the study. And then the final piece, and we won't have time to get into this during this talk because we want to leave room for discussion, is this doesn't have to be entirely linear. As Kirstine and others were mentioning today, we know that we lack effectiveness data for many of our interventions, but we can use some type of hybrid design to really gather at least some data relative to implementation while we are also collecting our effectiveness or efficacy data. We can do those simultaneously to kind of make the most bang for our buck, if you will. So with that, I'll kind of turn it back over to Yuda to see if we want to facilitate any discussion.
I just need to unmute myself. Thank you very much, Suzanne, Kirstine, and Natalie. I think I'll do like this. So, and I want to open the floor for questions for what have been said, or if you have any comments or experience to share, that would be wonderful. Claire?
Well, I really just wanted to say a huge thank you to all three of Kirstine and Natalie and Suzanne. I thought it was a brilliant presentation, and it really helped make a lot of sense of this topic for me. So thank you very much.
It's not that we want you to force you to say anything, and we do have another slide with some tips. So should we, Mark?
Hi, thank you all again. Just to echo what Claire said, that was really, really helpful and accessible. I just wanted to ask you what you think about ensuring that you have theoretical coherence in the work that you're doing. So recently, we proposed to do some work with a colleague where we were trying to combine implementation science approaches within the context of a realist evaluation approach. And we were criticized that it was too ambitious to try and do this and it would lack coherence. And so, and I hold my hand up to say I'm a novice at in these areas, but we did have a realist expert on the team and people who were experienced in implementation science. So just wondered if you have any tips about convincing people that it is possible to combine these approaches in a coherent way. Maybe that's a tall order.
Natalie, is that you?
Yeah, well, sure. I'm happy to.
Yeah.
Okay, I'll just leave a little bit. So I think one potential solution, and again, I think this is I appreciate you bringing this up because it's a very common issue. I think to think about and explain, to reviewers, this continuum that we have between explanatory and pragmatic work, right? So if you potentially lose a little bit of that internal validity because you allow your protocol to potentially be a little bit more modifiable, maybe you will have more external validity versus in a more controlled explanatory approach where it's critical to have, very high treatment fidelity. So really kind of thinking, for me, it helps to think about what are exactly the core components of what I'm trying to implement and what can be modified, So Brian Mittman in implementation science, he talks about something called form and function. So the form of what you're doing in terms of it being modifiable could change, but the function is what needs to stay put. So I think explaining that if the purpose is to be more pragmatic, if the purpose is to be implemented with more external validity, as opposed to, and acknowledging that, yes, I know what an explanatory trial is, I know about the importance of internal validity, but this particular project is seeking to be more pragmatic and really try to tease out what can be flexibly adapted for the purposes of higher uptake in the local context. I'll turn it to Christine to see if she has anything else.
I was just going to say that I think sometimes there's lots of different theories and approaches that can apply and you might have used, and it's always a balance to provide a rationale for why you've done that. And in one of a workshop I went to a few years ago with Ian Graham, who developed the knowledge to action framework, he was mentioning as well that sometimes in order to simplify it, you do need to take something out, even though it was there and part of it, just to make it more accessible to others. So I think if you feel really strongly, and it was in a critical part of the project to have that, there's always new ways of bringing ideas together. But I think sometimes we do need to think about not overcomplicating it. Not that I'm saying you were, but sometimes we might have 2 or 3 frameworks and we think, okay, we don't need to talk about every single thing. So I guess that's just the flip side of that as well, having a really good rationale for why, and maybe going to someone else who's not so critical, which is always hard, isn't it? But yeah.
Yeah, thank you.
Suzanne, what do you want to add? I saw you wrote something in the chat.
No, it's probably more coherent in the chat.
Yeah. Annalisa?
Thanks, Yuta. Thanks for the really, really useful presentations. And also that, the slide about the myths, because so I used, so when doing the CPT adaptation and trialing it in the Indian context, obviously there were a lot of like organizational, cultural barriers, as well as like attitudes to rehab. And so I used the Starman framework frame to kind of document how I was doing the adaptations and to kind of ensure that core components of the CPT training. So I used the Connect Conversation Partner scheme, which is more generic, but I used it for family members, considering the resource constraints in the Indian context and a lot of the barriers that we were, that are present and that we found when trying to adapt CPT. So I used and it was a very pragmatic approach. So we developed a very scripted kind of intervention, but also there was a very firm protocol, and that changed because of additional barriers that we had encountered, during the process, and kind of used Frame to document all of that. But when you were talking about the knowledge to action framework, I feel like, even using the two together, but I kind of just stuck to Frame. But because it was quite a pragmatic approach, I feel like the two may, in terms of reporting it now, when I'm writing it up, that could be really useful as well. So yeah, it was just really useful to hear the different frameworks, and also the fact that we don't have to just stick to one when using it or reporting it. That was really, really useful. So thank you. We are actually trying to use Frame for the COMTIL international adaptations as well. Yeah, but I think we kind of try to make it as accessible, but I think it is a bit complicated. Some of the teams are finding it a bit complicated to kind of map the adaptations, and also then when implementing it to the framework, but hopefully we find a way around that. But yeah, thank you.
I'm really glad that you're using that. I've been looking at that frame as well. And I think it's important for when you're doing training over time. Often you get a bit of a drift, like you adapt things as you go because you see what might work better. And then down the track, it's hard to keep a record of what you changed and why. So I think that will be important, although it's probably quite tedious to do as you go, but to really understand what changed, I think that will be great.
Yeah, I think the other really thing that appealed to me about Frame was that the consideration for the cultural and the contextual areas of adaptation at various levels. So that was really useful because they had specific categories for it where you could also document the reasons. So I thought it was quite comprehensive in that sense as well. But I think that's what makes it tedious as well. But yeah, thank you.
You both. And Maren?
Yes, if there's time, Jidde, I could also maybe email Christine, because I think I have a question for you. But could I just try maybe 1 minute? I'll try to ask the question. Yeah.
Sure.
We're writing a project for funding. And we're in the Netherlands. I'm Maren from the Netherlands, and we're planning to do an implementation project for a Dutch CPT intervention as well as a Danish one. So I'm working with Jidde on this, and we're going to use TDF for mapping barriers and facilitators. We'll use the BCT for selecting implementation strategies, and we'll evaluate implementation outcomes such as adoption and implementability. But we're also thinking about how to evaluate the process of implementation. And I was very happy, or, it was very useful for me to hear about the different kind of models, such as the process model and the determinant models. So what would your tip be to use a model just to evaluate the process of implementing? Because the model you were talking about, I think, was also very useful for selecting strategies and categorizing the barriers and facilitators. So yeah, my question would be, is there a model that we could use for merely evaluating the process of implementation?
I think Natalie can probably speak to this as well. There's, of course, yeah, I was going to say there's quite a lot of models. And Mark was mentioning the realist approach as well. And I've seen some process evaluations that have used a realist approach. I'm planning a process evaluation now, and I think we are using the CIFA with a team of people, and I'm not as familiar with that, but they do look at a logic model, and I think perhaps Natalie has more experience with that. But my experience with process evaluations is they're messy, and you don't know how it's going to fit together until the end, really, because you don't know what the results are going to be. And that's a balance, again, of collecting data that you think might be helpful, but then not drowning in too much data and not knowing what to do with it. So, yeah, I don't know if you had anything to add. That's probably not like a prescriptive response. I don't think I have one way. I've tried a few, and in my experience, it's been messy. And then the way I write it up might not be how I thought I would do it. So it's a bit vague, sorry.
Yes, no, I agree, Christine. I was going to mention the CIFR because there's the CIFR they have a wiki online that helps you. It guides you in terms of some qualitative questions. It helps you with interview guides and focus group guides that might help route your interview in terms of the implementation process. So I was going to recommend the CIFR as well, especially since there's a starting point available for helpful questions. But I agree in terms of the messiness, that's for sure.
Thank you both. That's very useful.
The other one that just came to me would be the MRC. Is it MRC framework that I have used, and it's quite nice. Again, it overlaps though. So sometimes I think it can be a bit complex, but if you have a look at the MRC guidance on process evaluations, that is really helpful too.
Good.
Thank you.
Thank you all, and thank you not least to Christine and Suzanne and Natalie for taking us through some complicated stuff this morning or midday or afternoon, wherever you are. And thank you all for coming here and joining us. And I do think we had a slide with the time for next talk, didn't we? We also have more slides you can see. No, maybe we had moved that actually. Anyway, follow updates from Kat.
And I'm sure we can share those slides too.
Yeah,
I know that there's a lot of content there, but we thought that might be helpful for people.
If you want the slides, I'll just quickly put my email into the chat, and then we are happy to share. And yeah, we will somehow try to figure out how to get the message out to all working groups that we are doing another talk. Talk number 2 is on the 31st of January, same time. And the last talk, the third talk, is at the 2nd of March. So one late January, one early March. And thank you so much, all of you, and have a good rest of the day or night.